Bismillahirrahmanirrahim. We will be discussing the evaluation of vertical strabismus. My name is Dr. Khawaja Khalid Shoaib, and I did FCPS and FRCS in 94 and 5, and then did pediatric ophthalmology fellowship from Australia, and later on became interested in medical education. Did my MCPS HP diploma in medical education. So I was invited as an examiner in 2007, and then for 10 years I kept on attending the examination, but now it is difficult for me because of commitments to spare 3 or 4 days. So I will be discussing basically the vertical deviations and how to evaluate them and how to go for the management. So the vertical deviations include hypertropia, hypotropia, and DVD. And when a patient comes with a vertical deviation, we ask the history. So anybody who can tell what are the things we ask in the history? Asking about the history of trauma, which can lead to fourth nerve palsy, orbital floor fracture, peribulbar or retrobulbar injection, which can lead to injury to the trochlea or to the inferior rectus. Thyroid dysfunction is very important, and we will see how it affects the eye. So the clinical examination starts with noting the head posture. We want to see whether there is any abnormal head posture, and if there is face turn or there is head tilt or chin depression or elevation, and sometimes there are facial asymmetry or craniofacial abnormalities. For example, in this girl, the mouth is tilted towards one side. So there is developmental abnormality of the maxilla. You see again that there is a head tilt and a face turn. So how you identify the face turn? By looking with, can you see both ears equally well? No. As I can see the left ear of the patient more clearly, so the face is turned towards right side, and similarly the head is tilted towards the right side. Okay, so next so this is again a patient, a Duane's patient, and you can see, I can see the right ear more clearly, and so the face is turned towards left side, and after doing the surgery you can appreciate that the abnormal head posture has been corrected to a large extent, but still you can't see both the ears equally well. So there is slight left face turn still persisting in the patient. Okay. So what about this one? There is apparent divergent squint, but what else? That the eyes are prominent, so this is a patient of craniofacial abnormality and there is proptosis. So we have to deal with the orbit first and then we come to the squint. So always treat the orbit first. Then coming to the ocular examination, we have Bruckner test, Hirschberg test, Klimsky test, cover uncover, alternate cover, and Prism alternate cover test. So what is Bruckner test? In the Bruckner test, we throw the light with the help of a direct ophthalmoscope and we observe the fundal glow, and you will note that the deviating eye is lighter and brighter. Another use of Bruckner test is to detect myopia or hypermetropia. So if you see the light is more on the upper side or lower side of the fundal glow, then you come to know that there is ametropia. Right. So the next is Hirschberg test. We all know whether the light reflex is present on the pupillary margin, then it's 15 degree or 30 prism diopter, and if it is present on the margin of the limbus, then it is 45-degree or 90 prism diopters. In Krimsky's test, we place a prism in front of the deviating eye and see, by increasing the amount of the prism, we see whether the light reflex has come to the center of the pupil or not. So the amount of the prism which gives the light reflection a central place in the pupil tells us the amount of the squint, and this is Krimsky test. In cover and cover test, we detect the manifest squint or the tropia. And when we uncover, we test the phoria. We can differentiate between a heterotropia and a heterophoria. Right. In alternate cover test, we shift the cover from one to the other eye, and it detects both the heterophoria and the heterotropia. So it gives you total deviation. What is the total deviation? And in Prism alternate cover test, we move the occluder from one eye to the other eye, and we keep a prism in front of the deviating eye. And when there is no movement of the eye, again I will show you a video to demonstrate the Prism alternate cover test. After checking the muscle balance, we go for the versions. And these are the 9 positions of the gaze: the primary position, up gaze, down gaze, and the levo version, the dextro version, now the dextro elevation, dextro depression, levo elevation, levo depression. And then if there is limitation in vergences, then we go for ductions, limitations or overactions. And then we check for convergence or divergence. And what is normal ACA ratio? We see how much is the convergence when we move our fixation from far to near. So normally, if there is 3 prism diopter of convergence, it is normal. But if it is 9 or 10 prism diopter of convergence, when we do a 3, when we look from far to near, then this ACA ratio is more. So we can note what is the convergence. Now these are the fixating targets. You see there are details in each fixating target, and we ask older children to read the letters so that patient concentrates and accommodates. While in case of the younger children, we ask some details. Where are the eyes, or how many petals of the flower are there, so that the patient concentrates and fixates, and then we see the amount of the skin. So part 3 step test includes identifying which eye is hypertropic, in which gaze the hypertropia increases, and the Bialchowski's head test, which head tilt give rise to more hypertropia, increase in hypertropia. So there's another way of reaching the conclusion in vertical muscle palsy. One, we always identify which eye is hypertropic. For example, in left hypertropia, there may be these 2 muscles on the right side and the left side. So there are a total of 4 muscles which any one of these can be paretic. Now, if we ask the patient to tilt the head, and on ipsilateral head tilt, if the hypertropia increases, it should be an oblique which is responsible. And then we ask the gazes, and in horizontal gaze, if on ipsilateral gaze the hypertropia increases, then it should be an inferior muscle, inferior rectus. So this is how we reach the diagnosis. Now, if you concentrate on this diagram, on this photo, it's difficult to see, but a closer look will tell you that the left eye is a little bit hypertropic. You can see the limbus on the left side, but it is not visible in the right eye. See, so the left eye is deviated upwards, but by looking at the eye, you can't say whether it is a hypertropia or this is DVD. So I have labeled it as left eye deviated upwards. Now look at this video, and I have covered the right eye. The left eye has moved from up position to down, and on uncovering, the right eye takes up the fixation. The right eye takes up the fixation, and so this is alternate cover test. You shift the cover from one eye to the other eye directly without covering and uncovering. So there is left hypertropia. Now you ask the patient to look in the right direction, and there's hardly any difference. But when you ask the patient to look in the left gaze, you can appreciate that the left eye goes up. So the left hypertropia is increasing in the left gaze. This is again in the right gaze, not hardly any difference, but in levo elevation, you can appreciate the difference more. So left hypertropia increasing in levo elevation. So after checking the muscle balance, cover uncover, and alternate cover test, we go for ocular movements. And here we can see hardly any difference, but in levo depression, you can see the right eye has gone down, but the left eye, in left eye there is limitation of depression. So limitation of depression means that the inferior rectus is not functioning well. So you can identify which muscle is peritic. Limitation of left depression and increasing on levo depression. Right. So the next step is tilting the head. You can see on the left tilt, there is hardly any difference. But on the right head tilt, you can see the limbus of the left eye, but you can't see the limbus of the right eye. So the left hypertropia is increasing in the right head tilt. So we have to do these maneuvers in each case of vertical deviation. So the left hypertropia increasing on right head tilt. So we'll see the video. Here, this is how we proceed. We check for the ocular movement, see in which is the peritic muscle, and you can see in all the 9 positions of gaze. And when we see the down gaze, levo depression or the dextro depression, we always lift the lids for a clear view. And so we can do the ocular movements first, or we can do the cover and cover test or the alternate cover test, but we have to do the head tilt. This is the step usually omitted, and we forget doing it. Now in this patient, there was a displaced fracture of the left-sided greater wing of sphenoid associated with mild preceptal thickening in subcutaneous tissue, soft tissue edema in the left temporal region. So there was rectus damage. Okay, so this is another case. Now concentrate on the ocular movements. So always lift the lids when you are looking for the down gaze, and in the up gaze you can see there is limitation of elevation in the right eye. Okay, so right limitation of elevation. The left eye is going up, but the right eye is not. So in this photograph, you can clearly see the conjunctival congestion and a little bit of puffiness. The eye is more prominent. It is divergent, of course. But what comes to your mind with congestion and proptosis and puffiness? Thyroid ophthalmopathy. So thyroid ophthalmopathy is the #1 cause of proptosis, the most common cause, most frequent cause of proptosis in young or middle-aged patients. So there is mild proptosis with conjunctival congestion, And if you see the CT scan, the inferior rectus is enlarged. The tendon is not enlarged, but the rest of the muscle is enlarged. Thickening of the muscle belly with sparing of the tendinous insertion, thyroid myopathy. And just to remember the mnemonic, which muscles are involved? The mnemonic is I am slow. Inferior rectus most frequently involved, as has been involved in this case. Medial rectus, which mimics lateral rectus palsy because the medial rectus is restricted in movement. Superior rectus, lateral rectus, and then obliques. Okay, so next, this patient also had a history of trauma 2 months back. And can you appreciate any difference? Hardly, difficult to see. But when you do ocular movements, then you can see there is left limitation of depression. The eye is not going down, and this is increasing. This restriction is more in the levo depression. So again, there is the inferior rectus is not doing the proper job. Okay. So I will show you the video and we will see how we proceed with the examination. Okay, so I have covered one eye and let's see what if we uncover. Difficult to appreciate anything, but on covering the right eye, I feel that the left eye has come down to take up the fixation. So on lifting the cover, the right eye moves upward to take up the fixation. So there is right hypotropia. Now cover uncover test, this is cover uncover test. I am covering and uncovering, and this is alternate cover test where I shift the cover from one eye to the other eye, and I see on uncovering the right eye moves from down to up, so there is right hypotropia. Okay, so regarding the path 3-step test, we always do make this type of diagram, considering the 4 muscles which are responsible, which can be responsible for the hypotropia or hypertropia, and then in which gaze it is increasing. Let's say it is increasing in the right gaze. So these are the 4 muscles which are more active in the right gaze, and then on head tilt, if it is increasing on the right head tilt, then we encircle this one. So when the 3 circles coincide, this is the superior oblique. So the superior oblique palsy, which our patient we are drawing accordingly. Now this is the Prism alternate cover test. Now in examination, you will have to perform the Prism. You will have to use the Prism bar. It is present in all the examinations, and gone are the days when you would call the squint in degrees. Now you have to describe the squint in Prism diopters because you measure it with Prism bar, right? So this is how we measure it with a Prism bar. Because in this patient there was right hypotropia, or you can say the left hypertropia. So we are gradually increasing the power of the prism with the help of Prism bar. And in this Prism bar, you will notice that the apex of the prisms is upwards. So apex is directed towards the direction of the squint. You can see these are the numbers, how much is the squint. Okay. So another case, and let's see what can you appreciate. Again, the left eye is going up, but the right eye is not going up. So there is limitation of elevation in the right eye, and there is some conjunctival congestion. Limitation of elevation and conjunctival congestion. So this is more marked in this photograph. You can see neither the eye is moving up. The conjunctiva is clear on the left side, but congested on the right side. And you can see the thick belly of the medial rectus muscle. How can you say that this muscle is enlarged? What is the landmark of with which you sort of compare? See, the muscle should be as thick as optic nerve. If it is more than that, then it is enlarged. Okay, thickening of the muscle. And now another important step in the evaluation is diplopia charting. Diplopia charting you can do with a pencil, and if there is let's say horizontal squint, you can keep a pencil like this and you can compare in which gaze it is increasing. So patient will say, okay, in this gaze there are two images, but when you are plotting doing a diplopia charting in vertical squint, then you have to keep the pencil or the target like this in a horizontal direction. So the perfect way is to use the red and green glasses, and we keep the source of light as a horizontal slit. And direction of diplopic image is opposite to direction of eye. Consider these are the two eyes looking straight, but when one eye becomes divergent, now the image falls on the temporal side of the eye, and temporal side is projected in the environment on the left side. So in divergent squint, the diplopic image becomes crossed. If the eye goes like up, the image will fall up and it will be projected downwards. So in hypertropia, the image will be down. Okay. So just to make you familiar with the diplopia chart, this is slightly different from the image diagram of cornea or retina. When you draw a cornea or fundus, then you make the fundus of the patient of the right eye on right side. See, but here when you are drawing the diplopia, you keep what the patient is looking. So this is the left field of patient's vision. This is the right field. So just keep in mind, this is opposite to the fundus diagrams. Now in this patient, you will appreciate that in the left gaze, the red and green images, the red image is coming from the right eye because the red glass is on the right eye, and the left image is coming from the green image is coming from the left eye because there is the green glasses in front of the left eye. So in the left gaze, the both images are superimposed, while in the right field or right gaze, the two are apart. Now how to tell which one is? So there is diplopia in the right gaze. So diplopia in the right gaze means that the right lateral rectus may be having palsy or the left medial rectus may be doing underaction. How to differentiate? If you concentrate, the green image is farther from the center. You see, this is the green image and this is away from the central place. So now is the second rule. The second rule is that the farther image belongs to the peritic eye. So because the green image is displaced more, the left eye is affected and the left medial rectus underaction. Now this is the opposite condition in which in the right gaze there is only one image. But if the patient is looking in the left gaze, there are two images. And because the further image, the image which is away on the periphery belongs to the left eye, so the left lateral rectus paresis is there. Now things become a little bit complicated in vertical deviation. Rule number 3, the maximum the maximum separation is in the field of paralytic muscle. Now, if you see in this direction, this is dextro depression. Now, in the lateral side, in the right eye, dextro depression is function in the right eye. Which muscle is doing the dextro depression in the abducted position? This is the inferior rectus. And which muscle of the left eye is moving? So this is my right eye and this is my dextro depression. Left eye, adducted position, my superior oblique is working in this condition. So either the right inferior rectus or the left superior oblique is paralyzed, and there are two images which are further apart, maximum apart in this direction. So again, you will note that the farther image is green. So if you don't have the red and green pencils or red and green glasses, then you can ask the patient occlude one eye, cover one eye, and you will see the farther image disappears. And you will come to know that this eye is having problematic muscle. You can give red and green pencils to the patient and tell, instead of plotting or instead of having a formal screen, you can just tell the patient to indicate with the red and green pencils. Okay, so one last point in this diplopia chart is that this is the quadrant right at 90 degree where the torsion is maximum. So the green light is maximum tilted. So there is one quadrant in which there is maximum separation of the two images, and there is one quadrant in which tilt is maximum. So these are the two things which you will elicit when you make a diplopia chart, and you can make a diagnosis of a vertical squint on diplopia charting only. Okay, so what is this? Okay, Maddox rod, and we measure the vertical deviation. Normally, when the muscle balance is normal, the light of we place it in front of the right eye. So, and to make a horizontal line, we keep the cylinder vertical. And if the normal muscle balance is present, then with the left eye, the patient will see the spot of light, and with the right eye, the patient will see a straight red line. And in case the right eye has gone up, there is right hypertropia, then the patient will see, because the eye has gone up, and now this part is stimulated, this will be projected as down. So the right hypertropia, the red line will be down. And what is this? Double Maddox rod. And we can measure the amount of torsion with this X cyclotorsion or in cyclotorsion. We ask the patient to move. We keep the red cylinders in front of one eye and the white in front of the second one. And when the red and white are parallel to each other, then we know that alignment has occurred, and this gives us the amount of torsion. There are other ways of looking at the torsion. And what are these? Now, these are some of the ways where we can see and we can note and we can record the cyclotorsion. See, now this is the normal fundus in which the fovea is present slightly below the center of the Okay, so the fovea is present just below the center of the disc, in between the center of the disc and the lower pole of the disc, right? But patient has come with this fundus, and you can see the fovea as displaced downward. So this is X cyclotorsion in the right eye. And after we did inferior oblique myectomy, now the X cyclotorsion has improved, and the fovea has reverted back to its normal position. Now this torsion is easiest to pick up with indirect ophthalmoscopy. Difficult with direct ophthalmoscopy because in indirect ophthalmoscopy the field of view is more, magnification is less. We can also have fundus photography, but just keep in mind that the head of the patient should be in primary position while taking the fundus photograph. We can also do blind spot mapping or iris photography, but again the head should be erect and in the primary position. Okay, so this is synaptophore and this is Bagolini striated glasses. Each one has its role, but I will not go into details. The Maddox wing, we can detect the near phoria, tropia, and cyclotorsion with this one, and this is the IIR Cyclo deviation test, and this is more familiar one, the Hess chart, and you can see in the left, again this is for the left eye and this is for the right eye. You can detect underaction of the muscle and you can detect the overaction of the muscle. So this is the left eye, and you see in the adducted position, this is the nasal. These are the nasal parts and these are the temporal parts. So you can see the underaction is in the adducted position, and we know that in adducted position it is the superior oblique. So this is the left superior oblique palsy. Okay, so what about this one? Where is the underaction? Where is the overaction? So here is the underaction. Here is the overaction. So where is the underaction? There is right superior oblique paresis, and there is corresponding inferior oblique overaction for right fourth nerve palsy. Okay. So this is a least screen and Lancaster red beam test, and these are the goggles, amploscopic. We can measure all the vertical and horizontal deviations, and they have the head mounted laser for target display, and patients sequentially fixates on the 9 positions, and infrared cameras, and all the eye movements are recorded. Now this is a practical step in what is this being done. So this test is known as force reduction test. Yes. So we move the eye in all directions of gaze. See, we have to do this test before doing any type of squint surgery, whether the squint is paralytic or concomitant. We should ideally do force reduction test in each case. But in paralytic squint, we always do it. We assess the passive movements and we differentiate whether the underaction is because of the palsy or mechanical restriction. For example, to rule out the superior oblique laxity, we have to move the eyeball in the upward position, and then we extort it and we push it back so that the superior oblique tendon is maximally stretched. And otherwise, we'll discuss in superior oblique surgery. We can also pick up the muscle, and if we can pick up more than 9-10 millimeters away from the globe, then the superior oblique tendon is lax. Okay, so there is another force generation test in which we assess the potential muscle function, and when there is known mechanical restriction, and we ask the patient to we get hold of the muscle with the help of 2 tooth forceps, and then we ask the patient to move it in one direction, and we appreciate how much force the muscle is generating or activating. So this is force generation test.